We're going to talk about benign hepatobiliary pathology imaging today. First, talk a little bit about the thought process when you're ordering a right upper quadrant study. We'll talk about biliary obstruction, stones, and portal biliopathy. And then inflammatory diseases will be most of the time infectious cholangitis and sclerosing cholangitis. So at the end of this lecture, you should be able to list and categorize the most common benign pathologies. I want you to be able to recognize and differentiate them by their imaging findings, and then use this information to order the appropriate imaging exams, and then be able to weigh the strengths and weaknesses of each of those exams. So, I want to just compare and contrast different imaging modalities when you have a patient with symptoms referable to the liver or biliary system. So ultrasound actually has the highest resolution. You can pick up small stones in the gallbladder that you can't pick up on MRI sometimes. It's fast, it's portable. The major weakness with ultrasound is that you often can't see the distal CBD because of bowel gas. So we can almost always see it in the hilum, but not distally. Of course, if you're ordering a right upper quadrant ultrasound, you won't see other causes of pain. For example, if the patient has a right-sided kidney stone. And then depending where you are, your sonographers may or may not have excellent skills. CT is fast. You can definitely see other things that are going wrong, widely available. The major weakness with CT is that you can't see gallstones and CBD stones in about 70 to 80% of patients. They're not radiopaque. Of course, you have radiation exposure, so it's not good for following patients with chronic hepatobiliary disease. But overall, it's excellent, I would say. MRI has the best sensitivity for CBD stones, especially MRCP. Of course, the lack of radiation makes it best for monitoring chronic conditions like PSC. It's got the highest sensitivity for malignancy detection and characterization based on, T2 signal, DWY, contrast enhancement. We just have a lot more tools with MRI to characterize tissues. Of course, this takes a long time. Sometimes our exams, even short ones, are like a minimum of 20 minutes. Sometimes they go to an hour. And so if somebody's got suppurative cholangitis and unstable, you don't want to send them to the MRI scanner. And then the cost is more than the other two modalities. Keep this image in your mind, the normal appearance of the biliary tree. So you guys know this anatomy already. I want to just point out how nice and smooth the ducts are. They're nice and thin. There's no beading, no stricturing, no dilatation. You can see the pancreatic duct real well. You can even see like the higher order ducts out here almost to the periphery. So this patient has a nice looking biliary tree. Here's what it looks like on ultrasound. The CBD has nice thin walls. You can see a little bit of fluid in the lumen. And then on CT, normal bile ducts, you shouldn't really visualize them on CT other than centrally, but notice no peripheral ducts on this one, and then the image on your left just for comparison. So let's talk about choledocholithiasis. Choledocholithiasis refers to gallstones within the bile ducts. They can present with biliary colic, ascending cholangitis, obstructive jaundice, or pancreatitis, and these stones may arise from the gallbladder and travel through the cystic duct to the common bile duct, or they may form de novo within the duct itself, even after cholecystectomy. So just because someone has had a chole doesn't mean they don't have possibility of choledocholithiasis. Ultrasound's often the first test ordered for suspected obstruction. It's kind of like a knee-jerk reflex, and I think that's fine as a first choice. It just has low sensitivity, like we mentioned before, for distal stones. CT is also not the best test, but it's often ordered when something else is suspected. and so you'll often, get a scan for rule out stone and sometimes just end up seeing dilated ducts which weren't even suspected. Um, so it's good for sort of like, is there ductal obstruction or is there not? And, it can visualize a lot of different pathologies, cholangiocarcinoma, um, you know, inflammation, cholangitis, etc. But again, you can't see most stones. So MRI and MRCP are really the gold standard. They're just as good as ERCP for detection of small stones. You don't need IV contrast, although it's often given. And the MRCP specifically refers to these heavily T2 weighted images where you can only see the ducts and not much else. If you could mute your microphone, that would be good. Whoever's does not have it muted. Sorry. And also, so MRCP also refers to the exam itself. So a lot of places will just do, 4 or 5 sequences, no contrast, just the T2s. It's fast, and that's called an MRCP. We usually do more sequences, including contrast, because we don't want to just get a view of the duct, but also the surrounding structures. And usually, acutely, this is order where the diagnosis is still unclear after ultrasound or CT. And of course, MRCP is the main diagnostic test for the bile ducts, whereas ERCP has changed to more of a therapeutic examination, unlike 20 years ago or longer when it was also used more for diagnosis. But given the rate of complications, we try to reserve it for patients with known disease. So in ultrasound, the stones are little bright dots. They shadow posteriorly. The shadowing is easier to see in the gallbladder than in the ducts. You can also see a twinkling artifact where on Doppler you see like little dots of what looks like flow, but it's actually an artifact, and that can be helpful. And then, if you have stones in the gallbladder and billedils, that increases your suspicion. So normal bile ducts should be less than 6 millimeters. So billedil is defined as greater than 6 millimeters plus 1 millimeter per decade over age 60. It's measured inner wall to inner wall. Of course, after cholecystectomy, your ducts are allowed to be a little bit larger in caliber as a reservoir effect. And the intrahepatic ducts are defined as greater than 2 millimeters or 40% of the adjacent portal vein diameter. That being said, I never measure the intrahepatic ducts on any modality. It's kind of like it when you see it, but that is the technical definition. So here's a nice stone in the gallbladder. It's round, it's echogenic. This is the shadowing back here. This longitudinal, you can see it, same thing. Here's a case from here where, this is a non-color Doppler and this is a color Doppler. And color Doppler is good for seeing what is vessel and what is duct. So, for example, this, you wonder, oh, could that be a bile duct? But no, it fills in with color Dopplers, so that's a portal vein branch. And then this structure here that doesn't fill in with color is a little dilated bile duct there. So there's a ton of gallstones in this gallbladder with a lot of posterior shadowing. This is these stones here in the bile duct are sort of lined up in a row, and you can see that each one of these has some shadowing. On this long view, you can see them also, but notice how you don't see the shadowing. And so, you know, although these are clearly stones, sometimes you'll have material in there that doesn't shadow, and so you sometimes don't know, is that a dilated duct or not. But in this case, we actually visualize the pancreas. The pancreas is not well seen usually on ultrasound because of bile gas also, although the head and unsnit are more commonly seen than the tail. And this pancreas here is sort of plump and edematous, and there's a little bit of fluid here anteriorly, which you can see. So this patient had gallstone pancreatitis and cholangitis. And here's the ERCP image, and you can see all the stones in the bile duct and the mild dilatation here of the intrahepatic biliary tree. You can even see the stones in the gallbladder. So CT, the stones are easier to see on non-con. Contrast makes it harder to see, but it's often subtle. Of course, Bill is also seen. So here's a non-con scan. This is a 90-year-old man who came in with abdominal pain, sepsis, and a bili of 5. And you can see here on the coronal, all these stones lined up in the bile duct. And then here it is on the axial. You see this high density within the ducts. These are clearly visualized as stones here on the coronal, but other things that are high density in the ducts, you have to think about hemophilia. This patient, because of his age and comorbidities, they decided to make him comfort care, and no intervention was performed. So let's look at choledocholithiasis on MRI. They look like dark dots in the biliary tree. It's the best study for ascending cholangitis, and really, again, this is not necessary if you already have the diagnosis by ultrasound or CT. MRI should not delay ERCP. So here's a 56-year-old woman with abdominal pain and choledocholithiasis, and so you can see here in the bile duct all these tiny stones just filling up the entire biliary tree. You see the stones in the gallbladder, and then this is an axial, and you can see them all lined up. Notice that they are layering dependently, which is important. So this is MRCP. What's the difference between that and MRI? Well, you see here when you do these normal T2s that you can see the liver and the kidneys and the spleen and the pancreas, etc. So obviously this is like valuable information. Of course, it doesn't in this case really add a whole lot, but I just added this to show the difference between MRCP and MRI. So here's a pitfall. So this is a 43-year-old man here, and you see that on the MRCP and on this T2, you see this tiny dark dot in the center of the duct. It's not layering posteriorly. So like, oh, is that a stone floating in the middle there? But you get another sequence here, and you notice that there's no filling defect in the duct. And so this is a known pitfall. This is flow artifact within the duct. So the flowing bile actually can create this artifact, which can be confused with a stone if you don't know about it. And it's only certain sequences where this happens. Some sequences are less prone to this artifact. And so this illustrates the point that you should look at all your sequences, not just a few of them. This patient is a 62-year-old man who had an ERCP and had some pain right afterwards. And you notice that there's this like dark signal here in the bile ducts. But what's odd about this case, those dark filling defects are actually not layering dependently. They're on top of the liquid. So you're suspecting that this could actually be air in the bile duct, and when you get your in and out of phase, you notice here that this dark signal becomes more prominent here on the in phase, which is called blooming artifact, and that's what uh, confirms that this is indeed gas. So this is not pathologic. Now this person also had an ERCP, 39-year-old guy, and you see that there are filling defects here in the duct. You don't see the distal duct, it's full of something. Then again, layering dependently there. But then you look at your non-contrast T1s and you see that there's high signal in the duct. So what could that be? What is bright on T1? Well, one of the possibilities is blood. And that's what this was. The patient underwent repeat ERCP and they took out clotted blood from the bile duct. So high signal on T1 can indicate hepatobiliary hemophilia, so keep that in mind. This is a 47-year-old woman with acute right upper quadrant pain, and you can see that there's this filling defect here in the distal CBD. Notice it's not seen on the MRCP very well. You've got this like overlying structure here, and so these MRCP images are sometimes presented as thick slabs, and so it's not just a 2 millimeter slice. It may be a slab composite of 20 centimeters, and so anything that's in that slab can overlie and then actually cause obscuration of the stone. And so again, it's important to look at all of your sequences. Now you give contrast. The contrast also adds value because you can see all of this heterogeneous enhancement in the arterial phase. And this sort of patchy arterial enhancement is very characteristic. Well, I shouldn't say it is a characteristic finding, although it's not a specific finding for cholangitis. And that normalizes on the delayed phase images. So these aren't hypervascular lesions. This is a patient with cholangitis. This is a 57-year-old woman, and what do you see on this image here? Interesting. Looks like there's bowing of the common hepatic duct, and there's some signal void here between the gallbladder and the duct. And then on the coronal, you can see that there's this large dark structure, and that's like a big gallstone. So this stone in the neck of the gallbladder is causing mass effect and biliary ductal dilation. So what's this called? This is Moritsi's. Yep, this is Moritsi's syndrome. We're going to talk about portal biliopathy. I don't know if you guys ever see this, but it can be a dangerous thing to miss, and I'll explain why. So portal biliopathy happens after your portal vein thrombosis and you get cavernous transformation. And the dilated vessels, these peribiliary collaterals, actually form like what's called a portal cavernoma. It's sort of like a mass, and it compresses the bile duct and can cause biliary ductal dilation. And so this can present as ductal obstruction, but also hemophilia. It's best seen on CT or MR. You can also see it on ultrasound, but the cavernous transformation, all those collaterals make the portohepatis sort of hard to see. And on endoscopic ultrasound, you guys would also see all of this, these tortuous vessels, and that's why we use color Doppler, because you could mistake these for like a mass, and you wouldn't, of course, want to stick a needle in these vessels. And so ultrasound is also key, but can be more confusing. You see biliary stenosis, wavy bile ducts, and then importantly, you can mistake this for a hypervascular mass, which I've seen before. So this is a 59-year-old guy with chronic liver disease, and he has biliary ductal dilation. You can see that there's a cutoff here right at the hilum with biliary ductal dilation. But on this MRCP, you can't see the cause. So on the single shot T2, vessels on T2 are noticeable by flow voids. So you have dark signal within the vessels, and you have this like tangle of vessels around the duct. And then you can see the duct right there, just kind of bloop, ending. And then you have all of these tortuous vessels in the hilum, and they're going into the liver and reconstituting the portal vein. You can see the little bile ducts in the periphery, which you shouldn't see. And then on this coronal view, you can nicely see all of these little vessels crawling up around the porta hepatis and into the liver. So this is portal biliopathy. Here's another case on this MRCP image here. You can see that the duct terminates. You actually see the distal duct here, which is not dilated. And then on this movie here, you can see you see kind of like this hyper intense stuff in the pancreatic head, which is sometimes why it can be mistaken for a mass. But then you see all these collaterals reconstituting the portal vein and the biliary ductal dilation. And again, that is portal biliopathy. This is a T2, so now again we're looking for flow voids. Look at the IVC, SMV, SMA. So as we get up here into the head, you can really see all of these like flow voids in there. And there's the distal duct, which is not dilated. And then, bloop, you see the common duct sort of terminating right there in the vessels, and then the biliary ductal dilation. All right, let's talk about inflammatory disorders of the ducts. These are the entities we're going to talk about. So ascending cholangitis, we already saw an example of that. It's typically a clinical diagnosis rather than an imaging one. For imaging, you're looking for biliary dilatation and stones. On ultrasound, you can actually see a thickening of the bile duct wall. And then, of course, the bilidal calculi. Sometimes you can see pus in the duct. CT and MR shows the same, plus that heterogeneous enhancement that I showed you. Here's an ultrasound image in a patient with hyperbilirubinemia, and you can see that wall thickening of the duct very nicely. The distal duct here is not inflamed. It's a nice comparison. It tapers normally at the pancreatic head here. Here's an MRI of a 37-year-old woman with right upper quadrant pain and fever. And you can see here that there's biliary ductal dilation. On this non-contrast scan, you can see this high signal stuff in the gallbladder, which represents sludge. And then you can also see that there's a little bit of heterogeneity in the duct there. When you give contrast, you can really see the thickening of the bile duct wall and the enhancement. And then the coronal also nicely displays that. So you can really see the wall here with the abnormal enhancement. And that's, we didn't see a stone in this patient, so they thought it was a recently passed stone given the stones and sludge in the gallbladder. And so this person didn't need an ERCP. They just got antibiotics and supportive measures and recovered. Let's talk about RPC, which is, I think, a very interesting disease on imaging. So you get intra and extrahepatic strictures and dilation with intraductal pigment stones. So you get choledocholithiasis and hepatolithiasis. You have to exclude other common causes, of course, and clinically there's your presentation. Often, like we said, in Southeast Asians, we don't understand this entity 100%, but infection with Clonorchis and Ascaris are thought to be involved. And you get periductal inflammation, so these white cells infiltrate the periportal space, causing fibrosis and strictures. MRCP is the best. Interestingly, there's not much wall thickening in these patients. You do see decreased arborization peripherally, so these what's called the arrowhead sign. You get segmental liver atrophy, especially the left lateral segment, and then hypertrophy of the caudate in segment 4. On CT, the stones are typically hyperdense, and then you get some other findings too, like fibrosis, heterogeneous enhancement, focal fat. So this is a patient here, came in with a history of RPC and increased LFTs, and this is the common bile duct here, which you can see is massively dilated, 2 centimeters. Notice that the duct wall itself isn't really thickened. It actually tapers here in the head of the pancreas, and then you can see it here, sort of normal caliber. And you can also see here on these images that we see some dilated ducts in the left lobe, which we see better on these high resolution images. So we see massive ductal dilation here, and then look at this sort of serpiginous duct with these huge stones just sitting in there. Notice that they don't shadow, neither do these. So just tons of intraductal stones. This is a CT on the same patient. And you can see, these bile ducts here are dilated, but we don't see intraductal debris. But these ducts here on the left are just chock full of stones. Here's the dilated extrahepatic duct. Notice how these bile ducts are sort of truncated here centrally. This is called the arrowhead sign, decreased arborization. And then this is another image, coronal, where you see all those filling defects. And here's the ERCP, similar findings, very few peripheral ducts. Here's an MRI on the same patient. So these pigment stones are often bright on non-contrast T1 images. We give contrast here, and you can see the parenchyma quite well on the bile ducts, and then we see these filling defects. And then also here on the post-contrast, you notice you see them a little bit better on the T2, but you can still see them here on the T1. And here's more images. These are the T2 that show you can have big stones like this square guy, but then also these teeny tiny stones, crystalline debris, etc. And there's actually also a stone here in the distal CBD, which you see on the MRCP, which probably isn't causing a whole lot of trouble, but maybe is. Different patient, 71-year-old female, also with a history of RPC. And you can see that, again, the left side is involved. This is a very common place. We see layering stone here and on the post-contrast. Now, unfortunately, this is something that happens with RPC or any other chronic inflammatory liver disease, is that they can develop cholangiocarcinoma, which we see here as high T2 signal lesion with sort of peripheral enhancement. So that's an intrahepatic cholangio. Move on now to PSC. PSC is an inflammatory condition causing biliary strictures, liver damage, cirrhosis. Diagnosis is made by imaging and clinical, and it's got a strong association with IBD, especially UC. It can be asymptomatic or have non-specific symptoms. No pathognomonic histological findings, but you get periductal fibrosis, periportal eosinophilic infiltrates, and paucity of ducts, especially peripherally. It's got associations with a lot of other autoimmune diseases. The entire biliary tree can be involved. In a minority, only the intrahepatic and proximal extrahepatic ducts are involved, but most cases, the entire biliary tree. It causes cirrhosis, but the cirrhosis looks different from other causes. It's got sort of a weird appearance where you've got atrophy of the whole liver except for the caudate, which is hypertrophic. And then, in most cases of cirrhosis, your left lateral segment will hypertrophy, but in PSC, sometimes it can atrophy. So these are little helpful findings. On MRI, MRCP, you see segmental strictures. They're usually short segment with intervening mild ductal dilation, which is called beading. The ducts don't dilate up that much because of the fibrosis. And so, when you do see a very dilated duct or a dominant stricture, we think about cholangiocarcinoma. You can see biliary diverticula, mural thickening and irregularities. We see delayed enhancement from the fibrosis, heterogeneous enhancement from cholangitis. And then, of course, we screen these patients periodically because of their risk of cholangiocarcinoma, which is most frequently perihilar. Ultrasound and CT are not that great. MRI, like I said, is a test of choice. This is a 23-year-old guy with UC and PSC who comes in with cholangitis. You can see the distal duct here is sort of normal in caliber. There's a little, looks like a diverticulum. The more proximal ducts are dilated. It's kind of ratty. And then you can see the beaded appearance of the ducts here where you get like dilation, narrowing, dilation again. Some ducts are not communicating centrally, so they're like jailed off. Essentially, this is the axial image. You see that there's not a lot of ducts in the periphery. And this, you can see the beading quite nicely, dot, 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 dot there, little dot, dots everywhere. This patient, this is what a cholangitic abscess looks like. It's got vague T2 signal, some arterial enhancement around it, and then you get this, they're usually small and peripherally enhancing, as opposed to like, what we're normally used to seeing in pyogenic abscesses, which are large and have a cluster sign. When you see these scattered about, don't just put your money down on metastatic disease. Often these are cholangitic strictures. This is a little duct here with some enhancement around it from the fibrosis. And then these are delayed phase images. We have another little abscess here. Notice this duct has, like, you can see the walls are enhancing around it. And centrally, same thing. You see the bile duct walls are thick and there's delayed enhancement from the fibrosis. Same thing over here. And this is higher up, and you see like a little duct that doesn't connect centrally. So sometimes, when it's mild, you might not see that much ductal dilation. But if you look around the liver and you ever see a bile duct that sort of doesn't go anywhere, doesn't connect centrally, that's a good sign of PSC. And here's an ERCP image for you guys that also shows the ratty looking duct, the pruning here peripherally, and the irregularity and beading. This is another patient, 23-year-old female, also with UC and PSC, who came in with some abdominal pain. And she's actually got this like hyperdense stuff, whatever gunk or sludge or stones, sloughed mucosa within her dilated ducts here. these arrows are pointing at the common hepatic duct, which is thickened. We have like a stricture here with this blown out sort of ballooning of one of these ducts. So, and then you also see that out here in the periphery of the left lobe. So this is a more severe case, and so this was done in 2009. This scan here, and that'll become important in a bit here. So on this image here, you can see her colonic wall thickening here and here from the ulcerative colitis. That's what I'm showing here on the right, this thickened wall and all these hyperemic vessels around the periphery. And then you can see the ductal dilation there. So this is what her liver looks like 5 years later. And you can see in that time that the morphology has changed quite a bit, has become like nodular, dysmorphic, and cirrhotic. She's got ascites now, edema in the mesentery, etc. And then this is also 5 years later, right before her liver transplant. And you can see the difference here now, how dilated the ducts are, much more severely. You can see like the beating and irregularity. These T2 images show this sort of bizarre appearance where you have these zones that are a little darker and sort of more normal in appearance in a way, but have these dilated ducts. And then you can see all of these little siderotic nodules here in the liver elsewhere, and this high T2 signal consistent with fibrosis. And then these are some T1 weighted images. And again, you see this bizarre dysmorphic appearance with these big hypertrophied areas that have actually more normal signal, and then this fibrotic, you've got this like lace-like characteristic of the cirrhotic liver. On the arterial phase, this part enhances, and then these poorly enhance, and it sort of normalizes on the portal venous phase, but not quite. So just a weird looking liver. Talk about secondary sclerosing cholangitis now. So this resembles PSC, but it's from another cause. Three main categories. So you can get chronic biliary obstruction with recurrent cholangitis, and that can be from, stones or surgery, biliary trauma, chronic pancreatitis, neoplasms. You can see this in liver allograft with anastomotic strictures. Ischemic cholangiopathy is another big category, so hepatic artery thrombosis in a transplant patient, rejection, intraarterial chemo or embolization can cause ischemia, vasculitis, radiation, and sometimes in critically ill patients with prolonged hypotension, you can get ischemic cholangiopathy. And then AIDS, crypto, and CMV, which we're not going to talk about today. Imaging findings are the same as in PSC. It's hard to tell the difference. So this is an interesting case. This is a 19-year-old kid who came in with no past medical history in 2015, and he had altered mental status and brain lesions and was in status epilepticus starting in August. And he had been in status for 4 months, unable to be effectively treated. And then he had rising LFTs, and so they got this ultrasound, and you can see here that you've got these like tubular structures out in the periphery and these hypodensities everywhere. You have the similar things here. You can see with the Doppler that those are not vessels. They got a CT scan. This is a CT scan on admission in August, which was normal. And then these are the images. This is only 4 months later, but you can see he's already developed like hepatomegaly. He's got splenomegaly also, and these are all like serpiginous dilated bile ducts in the periphery of the liver. Here you can see he's got a peg there. So this was thought secondary to ischemic cholangiopathy from prolonged critical illness and hypotension. Um, you know, ischemic cholangiopathy, status post-hepatic artery thrombosis in a transplant patient could look very similar. So this is just one cause of SSC. Now we'll talk about IgG4. So we're not going to go over this busy slide, but just to remind you that there are two types, 1 and 2. 1 has high IgG4, 2 does not. Type 1 is associated with all of these extrapancreatic organ involvements. Type 2 is not. So, the pathology is you get transmural ductal and periductal infiltration by these IgG positive plasma cells, causes fibrosis and obliterative phlebitis. The epithelium is normal, unlike in PSC, and the biliary tract manifestation, this is the biliary tract manifestation of IgG4 related disease. 90% of the time it's associated with pancreatic involvement, but it can occur in isolation 10% of the time. Up to 40% of patients with AIP also have IgG4-SC, and it's associated with type 1, not type 2. It can mimic biliary malignancy or other sclerosing cholangitis. The extrahepatic duct is involved more than the intrahepatic ducts. The intrapancreatic bile duct is the most common location, but extrapancreatic also occurs. And then, when it involves the hilar intrahepatic ducts, it can appear similar to PSC. So, compared with PSC, these are the differences. So, IgG4 causes cirrhosis later in the course. PSC has less ductal thickening. The ductal lumen is often occluded in PSC, whereas it's usually patent in IgG4. If you see these other findings like beading, pruning, diverticulum, etc., that you should think PSC, not IgG4. Focal strictures also, and then multiplicity of strictures and involvement in intrahepatic ducts also more common in PSC. Ultrasound is not that helpful. In this case, again, you can see like this thickening of the duct. Notice that the lumen is not obliterated. So although the duct is thickened, it remains patent. And look at this big fat juicy pancreas here. And it has this hypoechoic halo around it, sort of classic autoimmune pancreatitis. On CT, we see circumferential symmetric thickening of the ducts. Similar findings here. You have progressive homogeneous single layer enhancement. Cholangiocarcinoma is also a consideration or in the differential, but that enhancement pattern looks different. You can also see gallbladder thickening, and then of course involvement of the pancreas and other organs. So this is a patient who has autoimmune pancreatitis. You see in the center image here that there's this hypodense halo surrounding the pancreas. The pancreas itself has lost its normal lobulations. Here we see intrahepatic biliary ductal dilation. You can follow the common bile duct down there. And there it's dilated, but it's not thick-walled. On these coronal images, you can see the dilated duct, and it goes bloop and it gets obstructed right in the pancreatic head, but the duct is not thickened. So this is not IgG4 cholangiopathy. This is autoimmune pancreatitis causing ductal dilation. And you see again this nice halo here around the pancreas. So And this is after 10 months treatment with steroids. There's no longer bilbil, and the pancreas looks normal there. It's actually atrophic, which often happens. Oh, and you can see here on this image, there's like what looks like a lesion in the kidney. Here's another typical case. However, this person does have IgG4 cholangiopathy, not just autoimmune pancreatitis. So this is a nice sausage pancreas with the hypoechoic halo. And you can see here that the ducts are dilated, but unlike that other case, the walls are thickened. So this thick-walled appearance is characteristic of the IgG4 cholangiopathy. This patient came in with pruritus. You can see that there's autoimmune pancreatitis with this. If you can mute your speakers, that would be good. Although I don't know, maybe that just means somebody left. I think we're going to go a couple minutes over if that's okay. We're almost done. So again, there's thickening of this bile duct here, fat pancreatic head, intrahepatic biliary ductal dilation. So this has autoimmune pancreatitis and IgG4 cholangiopathy. Here are coronal images where you can really nicely see the ductal wall thickening there. This is a different patient who also has autoimmune pancreatitis and cholangiopathy. So this is a very bizarre looking pancreas, sausage shaped, halo. These are like massively dilated ducts within the pancreas itself. Here's a coronal, and you can see all of those renal hypodensities. So that's autoimmune or IgG4 involvement of the kidneys. So again, the cholangiopathy often associated with extrahepatic manifestations such as kidney disease. This is a really nice image from the literature, the 66-year-old guy with AIP, and you can see really impressive ductal thickening here and on the coronal also. So another big difference between PSC and IgG4 is that the ductal wall thickening can be much more severe in IgG4 than in PSC. So again, hard to tell the difference, but this severe ductal thickening should clue you in, and of course the AIP is a giveaway. We'll talk about MRI now. Here's a stricture at the common hepatic duct with bilbil on the MRCP, and then this delayed phase contrast enhanced study shows severe thickening of the ducts, but the duct remains patent. There's also like some delayed enhancement here at the confluence. Different patient, similar findings. This one has obstruction from the autoimmune pancreatitis, but doesn't really have IgG4 cholangiopathy because the duct itself is not abnormal. Another patient with IgG4, and you can see again this severe ductal thickening, nice autoimmune pancreatitis, and you can see on this DWI and ADC that there's severe diffusion restriction. You can get these weird mass-like areas centrally where you see like this, what looks like a hypointense mass at the hilum, this hypodense stuff here on the T2 and on the contrast enhanced images. You're like, what is this? Is this cholangiocarcinoma, lymphoma, metastatic disease? And you get progressive enhancement of the mass. So it'd be hard to rule out cholangio in this patient, but this was IgG4 also. We're not going to go over this, but there are many different appearances of the cholangiopathy, several subtypes. I'm just going to show you some pictures of cholangiocarcinoma. So you can see how this would be hard to tell the difference sometimes. Periductal infiltrating has a wall thickening and infiltration, delayed enhancement. Same thing here, you get, this is a mixed mass forming in periductal. So here's the periductal infiltrating part of it here. And then you've got this mass within the liver with delayed enhancement and upstream bile. So this is cholangiocarcinoma. I won't go over this slide, but when I'll pass out the deck, this image, this chart here nicely explains the differences between ISC, which is IgG4, PSC, and then cholangiocarcinoma. Just quickly, the extrahepatic is more involved in the intrahepatic with IgG4, whereas PSC has extrahepatic and intrahepatic. Mostly the length is longer in ISC, shorter in PSC, and the wall thickening is often much thicker in ISC and not as thick in PSC. So those are very helpful. This is in summary here. When you get ductal obstruction from a malignancy or a stricture, you tend to get this proportionate dilation of the extrahepatic and intrahepatic ducts. Recurrent pyogenic cholangitis usually has like tapering here, but then dilation of the intra and extrahepatic ducts, but you get the pruning and these little arrowheads here. And then PSC, of course, looks different with the beading and the strictures.